Hi, good morning. This is Claire, and I'm doing a presentation on cirrhosis. Cirrhosis has to do with the liver. So we do know the liver is a pretty regenerative organ on its own, and so one of cirrhosis is a chronic degenerative disease of the liver. So when cirrhosis is present, the liver cannot regenerate. So you're going to have these lobes of the liver. They're going to be become very fatty or filled with scar tissue, depending on the type of cirrhosis they have. And so parenchyma, which is the functional tissue of the organ, you're going to see it starts degenerating as those lobules become affected by that scar tissue and that fat. So again, the liver cannot regenerate while cirrhosis is present. And that disease progression can lead to liver failure or loss of function. That overgrowth of that scar or fatty tissue is going to constrict the blood flow within that organ. Again, that's going to cause that liver failure. And you're also, when it develops like hepatomegaly, which is an enlarged liver, or if it's going to have contractions, it's going to again affect that the liver and cause more loss of function. So cirrhosis is the 12th leading cause of death in the United States, and there are several different forms of cirrhosis. So the first one is alcohol-related liver disease. So as it says, it comes from overconsumption of alcohol. So alcohol, as most of us know, is a liver toxin. It's a hepatotoxin. And so what we'll see is with women, if they consume more than 2 to 3 drink alcoholic beverages a day, or with males, you'll see 3 to 4 drinks per day, they can potentially develop that cirrhosis, especially in the long term. So alcoholics can very easily develop cirrhosis. Their next one is post-necrotic cirrhosis. So this can occur if someone has hepatitis C, B, or D, or if they were exposed to some kind of hepatotoxin. So you may see, we can see this with patients if they've been taking a lot of acetaminophen or ibuprofen. We always want to warn of hepatotoxicity. That's the reason why you're going to see that post-necrotic cirrhosis. And you're also going to see it happen in infections. Of course, we know that infections can lead to necrosis, so you can see those with infections. Our next one is biliary cirrhosis. So that has to do with destruction of the bile ducts, which can cause inflammation. You're going to see some blockages happening. So it's, again, caused by chronic biliary obstruction, so blockages, so they can happen from gallstones. If you have gallstones, it can cause that. If you have chronic pancreatitis, so like our patient who had pancreatitis this past Monday, if they had it continuously, they could develop that biliary cirrhosis. And it could also happen with children who have underdeveloped biliary structures. Next one is cardiac cirrhosis. So you're going to see that with patients who've had severe right-sided heart failure for a long period of time. You're going to see it with patients who have constrictive pericarditis. You're going to see it with people with tricuspid insufficiencies. So a lot of that has to do with like a buildup of fluid, right? So that's going to be that cardiac cirrhosis. Our last one is non-alcoholic fatty liver disease. So this occurs, of course, there's a big fat buildup in the liver. And again, liver is going to cause that dysfunction. So you're going to see this with patients who are obese, morbidly obese. It's not the number one form of cirrhosis in the United States, but it is up there because we've been having this continuous rise of obesity in America. But as of right now, alcoholic liver disease alcohol-related liver disease is the number one form of cirrhosis. So again, alcohol is a hepatotoxin, so that's going to be, and a lot of people drink, so that's going to be a number one form. So we have 4 stages of cirrhosis. So it goes from destruction, inflammation, fibrotic regeneration, and hepatic insufficiency. So it's going to start with that destruction. You're going to see some inflammation happen. It's going to try to regenerate. You're going to see that fibrotic regeneration. And then it's going to ultimately lead to that hepatic insufficiency. So, meaning it's not going to be functioning anymore. So there's a multiple altered liver functions that happen. The first one is we're going to see the liver is not going to be able to synthesize albumin efficiently because of that liver cell damage that's happening. You're also going to see portal hypertension, and that's going to be caused by those obstructions. So those can be irreversible, unfortunately. The next thing you're going to see is ascites. So you're going to see me talking about that a lot. So ascites is a buildup of fluid in the peritoneal cavity. So as these obstructions happen, as these things are not being, as these enzymes or these all these things are being affected, and these different hormones aren't being stopped, you're going to see this large buildup of retention of fluid in the peritoneal cavity. Excuse me. So you're going to see a lot of that happening. You're going to see increased blood ammonia levels happening because the liver cannot metabolize protein effectively. And you also see a lot of alcoholic patients who just don't have enough protein in their diet anyways. This could also cause hypoalbuminemia, which is low levels of albumin in the blood, and which can reduce the blood's ability to maintain osmosis or regain it. So you're going to see that imbalance in the blood. You're also going to see hyperaldosterone. So aldosterone is a hormone released by the hormone released to stimulate the kidneys to retain sodium and water. So the liver is responsible for inactivating that, to stop it from happening. So if the liver's not functioning, it keeps telling the kidneys to build up that sodium and water. You're going to see that retention of fluid. So like we're going to see that ascites, the buildup in the peritoneal cavity. The last one is you're going to see a lot of vein distension, especially in the upper part of the body. So that is the esophageal varices, so those big abnormal veins on the esophagus. You're going to see these kind of spider veins. They're called spider angiomas, or I've seen spider telangiectasis. And you're going to see those kind of develop in the upper part of the body. So when it comes to clinical manifestations, early ones is the liver is going to be very easily palpated, and you're going to hear the patient complain of abdominal pain. Your late stages of clinical manifestations, you're going to see dyspepsia, which is indigestion. You're going to see change in their bowel habit, gradual weight loss. Again, that ascites. You're also going to see an enlarged spleen. So with the enlarged spleen and the liver's inability to help produce certain clotting factors, you're going to see a lot of problems with excessive bleeding, hemorrhaging, poor clotting, excessive bleeding times on these kinds of patients. So you're going to see a lot of symptoms developing from that. And again, of course, you'll see the big one, jaundice, liver dysfunctioning. You're going to see that jaundice happening from the bilirubin, malaise, nausea, ecchymosis, and again, those spider veins. So again, it's going to affect the GI organs. It's going to affect the spleen. As the spleen becomes congested, it's going to cause anemia because it's not producing red blood cells. The liver is also responsible for absorbing that vitamin K, so you're going to see vitamin K inefficiencies, and it's not going to be able to produce those clotting factors 8, 9, and 10, so it's going to cause those bleeding tendencies. So when it comes to our assessments, the subjective and objective data we're looking for. So with early stage cirrhosis subjective data, you're going to see some flu-like symptoms. And so you're going to see, of course, dyspepsia, that indigestion. You're going to see abnormal bowel functions like we talked about. They might have excessive flatulence. And they're going to, of course, have that abdominal discomfort. In early objective data, you're going to see low hemoglobin levels. You're going to see a fever, or you're going to see a high temperature. They're going to have weight loss as well as jaundice. So they could have weight loss, but then have a very distended abdomen. So it's good to take a look and make sure they're not looking emaciated or anything like that. So your late stage subjective data. So with the late stage, it's going to be all of the early stage data, but worse. It's going to be a lot more intense. Again, you're going to start seeing difficulty breathing. They're going to develop pruritus or itchiness, and that's from the buildup of bile salts in the skin, so they become very itchy. And you're going to see some severe fatigue. They're going to be very tired. More objective data, so you're going to see the epistaxis, which is the nosebleeds. Again, they don't have great clotting. They're going to have descended veins. You're going to see purpura, which is those red and bluish kind of splotchy, almost bruises looking like from kind of ruptured areas. You're going to see blood in the urine, hematuria, and the spider veins and bleeding gums. Again, they're going to have that poor clotting, and then you're going to see hemorrhaging and stuff like that. So Those are your assessment items. Additional symptoms you can see, again, the ascites. Again, with all of the effects in the spleen and the clotting factors, you're going to see some hematologic disorders, that splenic enlargement again, and the varices and just in the GI veins. Again, varices means abnormal veins. Again, with excessive levels of ammonia, you're going to see some altered mental status. They may not be able to speak efficiently. They have altered speech patterns, just abnormal behaviors that's not normal for them. So finally, when it comes to our diagnostic tests, so there's the big one is liver function tests, and that's going to test multiple different enzymes and protein and different hormones. So with that, you'll see abnormal electrolyte values. You're going to see elevated serum bilirubin, elevated ASTs, same with ALTs, LDH, and GTTs, which I did look up what GTT meant, and it's a glucose tolerance test. So again, you're gonna see a lot of effects with their glucose. So you're gonna see a decrease in total protein. Again, it's not metabolizing correctly. You're gonna see a decrease in serum albumin. You're gonna see elevated ammonia levels. You're gonna see a low blood glucose. You're going to see impaired glucogenesis. You're going to see a prolonged prothrombin time, so again, excessive bleeding. You're going to see an increased INR, and you're going to see decreased cholesterol levels through those liver function tests. So the next one is an ERCP. So that's an endoscopic retrograde cholangiopancreatography. So again, it's a scope, so they're going to send that through, and that's how they're going to be able to check and see if they have any bile obstructions that are causing the cirrhosis. They also can do an esophagoscopy with barium esophagography. You're also going to see an ultrasonography, as well as they're going to do paracentesis. So paracentesis can be used to alleviate some of that fluid in their abdomen, but they could also send off that fluid to the labs for general examination as well to do any tests that they need to do on that. So that's all I have, and thank you for watching.